My name is Annie Hockett, and I'm here today to talk to you on behalf of Prevent Child Abuse Tuolumne County, or PCATC for short. PCATC is Tuolumne County's local child abuse prevention council, and our council in the last 2 years have developed some curriculum around the topic of trauma and trauma-informed care, and that is what I'm going to be speaking to you guys today about. So when we talk about trauma, it's helpful to have a definition of what we mean. Essentially, trauma is any event or series of events that can be overwhelming to a person's sense of physical or emotional safety. What's important to remember is that what can be traumatic to one person is not necessarily traumatic to somebody else. There are obvious categories of trauma that we see. Any form of child abuse would be classified as a traumatic event. So cases of sexual abuse, physical abuse, emotional abuse, and all forms of neglect can be traumatic. There can also be situations that might not seem obviously traumatic to a child, such as divorce, maybe involvement in a motor vehicle accident, potentially a medical procedure that one has to undergo, and of course natural disasters. So when we say trauma-informed care, that's another topic that is helpful to have a definition of. And really what we're talking about there is that every person, every system, every service provider that comes in contact with a child that's been exposed to trauma is aware of what trauma might look like and is sensitive to the unique trauma needs that that child might have. The official definition I'll read for you. Trauma-informed care is an approach to engaging people with histories of trauma that recognize the presence of trauma symptoms and acknowledges the role that trauma has played in their lives. When we're talking about trauma-informed care, what's important to kind of remember is that it really requires a paradigm shift for all of us. If we can shift our focus and be sensitive to what trauma might look like in those that we work with, the world is going to look very different. One way that I like to think about this is if we change the question to what is wrong with that person or what is wrong with that child, and we flip it and instead ask ourselves, what has happened to that person or what has happened to that child, that will allow us to see things very differently. You know, when we go out into the community and we talk about this topic, we often encounter what we call kind of trauma myths or belief systems about this topic that we like to dispel kind of right away. One of them that we hear often is that trauma can be relatively short-term. And really what we know from the research and the science behind this is that this can have lasting effects on a child throughout their lifetime. We also hear, well, children just naturally can outgrow it. What we also know is that if a child has been exposed to some significant trauma, that they do oftentimes require interventions, whether that be from a professional organization or just the community. We hear that trauma can be relatively with a quick onset, and that certainly can be the case, but what we also know is that there can be a delayed onset in symptoms. We often hear that trauma cannot affect very young children, and actually the absolute opposite is true, that trauma can be most devastating to young children. We hear that one has to be kind of immediately exposed to a traumatic event in order to have a response. We also know that just by hearing about it, by seeing it on the television, by the newscast, that can also have an impact on children. So I think it's helpful to have a point of reference in terms of how prevalent trauma can be in our community and nationwide. So I'm going to share a few statistics with you. It's estimated that approximately 34% of children in the U.S. will have experienced at least one traumatic experience. 75 to 93% of children entering the juvenile justice system come with a trauma history. It's estimated that approximately 70% of adult inmates that are incarcerated were at one time in foster care, thus linking trauma histories to adult incarceration. And it's also estimated that approximately 25% of children before the age of 4 will experience a trauma. Okay. So I want you to take a minute to think about maybe a child you've worked with, a child you've known in your neighborhood or your community that has maybe exhibited challenging behaviors. So take a minute, think of that child. And then think about what behaviors you actually saw. So some that might come to mind include kind of agitation, anger, depression, withdrawal, aggression. You kind of name it in a child that has some difficult behaviors, and you can link that back to a trauma response. You know, a lot of our understanding of trauma comes with new kind of technologies and breakthroughs in brain science, and we can actually kind of look at a child's brain that has been through a traumatic experience and see the changes that can occur. What's important to remember is that if trauma is exposed at a very early age, the child's brain actually kind of develops in a disorganized way. So if we have a caregiver that's responsive to a child in those early years, that brain develops healthy. If we have an unresponsive caregiver or an abusive caregiver, that brain develops in a very disorganized way. So what's important to know is that the traumatized brain literally responds differently. So in a normal brain, when a threat is perceived, signals are sent simultaneously to multiple sections of the brain, the higher and lower sections. The higher area of the brain is able to really kind of do some processing of that and determine this isn't actually threatening. When you have a traumatized brain, that signal is only one way, and it tells the body, you are threatened, you better focus on survival. Another helpful way to kind of think of this is that try to imagine reasoning with a lizard. And I know that sounds funny, but a lizard lacks the part of the human brain that's able to kind of modulate their emotions and think critically. It's the same kind of way that a traumatized brain works. So if you try to imagine reasoning with a lizard or reasoning with a person that's been exposed to trauma and that are dysregulated, you're going to get the same results. So thinking back to that list of behaviors that I had you think of in terms of challenging behaviors of a kid that you might work with, you can really kind of classify it into three categories: hypersensitive, hypervigilant, or tuned out and shut down. And really, if we look at those three categories, it's all a form of dysregulation. And so when we really are talking about trauma and symptoms, we're talking about a child that's dysregulated. And as difficult as that can be, if we can step back and understand that that's a very natural response to experiencing trauma, it can make it a little bit easier to work with that youth. So kind of on that topic of dysregulation, you can kind of imagine what that might look like in a normal, healthy kind of human. And you can see on the slide here that that kind of ebbs and flows in a really natural direction. This is what it looks like when that person is dysregulated, or that person has kind of organized their brain around trauma and chaos. So you can notice it's quite different. So just to kind of sum up some of the key points of everything that I've been talking about, I want to remind you guys all that trauma victims literally perceive the world differently, and they view non-threatening situations as potentially dangerous. Again, if we can think about these behaviors as being a very natural response, a stress response to the circumstances of their environment, it makes a lot of sense. What happens to the brain when under intense stress or traumatized is that the brain cannot use all its capacity, therefore the ability to kind of think critically, to use logic, all of those higher functions kind of go out the window. What can be difficult about this topic is that you can kind of walk away feeling kind of hopeless, that once the damage is done, there's nothing that can be done to kind of help a child or an adult. I'll tell you that that's not true. There is hope, and I'll talk about kind of what that looks like. So I want to talk to you a little bit today about the ACEs study. And the ACEs study is kind of a landmark study that has really kind of changed the game for this topic. It was back in kind of the mid-90s, and researchers kind of just stumbled upon this. The background is a doctor out of Kaiser in San Diego was operating a weight loss clinic. And as he was working with patients, he kind of discovered, gosh, all of these patients have kind of adverse childhood experiences, or ACEs. So he partnered with the CDC, and essentially what they did is they looked at adverse childhood experiences and later health outcomes, and they were kind of floored with what they found. What they determined is that the more adverse childhood experiences one had in their past, the poorer health outcomes they had. They were able to link adverse childhood experiences with all sorts of public health concerns: smoking, substance abuse, suicide, mental health issues, depression, and obesity, heart disease, COPD, and cancer. They also were able to determine that the more ACEs one had, the poorer the outcomes. They estimate that there's a 20-year reduction in one's life with an ACE score of 6 or above. So I would encourage you to kind of look more into this research. It's all over the web, and it's really critical to kind of understanding what we know about trauma and how it impacts health. Okay, so I don't want to leave you today without some kind of tangible tips or things that you can try with the youth you're working. So what's really important is to try to be predictable and consistent. Traumatized children really need structure. That's not something that they've been used to, and they really crave it. Also, make sure that you allow children a sense of control. When children have been through a traumatic experience, that control has been stolen from them, and so it's important for them to feel safe and have control. Educate yourself on what trauma looks like, and know that when you have a child in that survival mode, what that is and what interventions are probably not appropriate at that time. The biggest thing you can do is just be there, listen, ask them how they're doing. Going back to the ACEs study, what the doctor found is that by simply asking patients about that history and showing genuine care, there was a 35% reduction in subsequent ER visits. So that alone tells you that it's just asking the question is sometimes the most powerful intervention that we can do. What's really important to remember is that don't try to approach and work with children when you yourself are dysregulated. It can be very easy to get frustrated, to kind of feel that you are kind of just struggling with how to work with this child. Kids can pick up on that, especially kids with trauma histories. They are so hypervigilant, they are aware of everything, and even if you think you're regulated and you're not, they will know. So make sure you step back, take a deep breath, approach them at a later time, because it's not going to be helpful if you are dysregulated. And really be comfortable making referrals and reaching out to other service providers in terms of how you can help children. There's lots of mental health clinicians that are really focused on this work, agencies that are really wanting to kind of help all those that work with traumatized kids, and so there's a lot of resources available to you. Just by being present for a youth can be some of the most powerful interventions that we know are out there. And I'm going to read you a quote that I think sums this relationship up very well. The brain develops in response to experiences with caregivers, families, and the community. And the quality of those experiences affects whether the child will develop a strong or weak foundation for all further learning, behavior, and health.